Welcome to the SVS interview series where we are interviewing pioneers in vascular surgery. Today we're interviewing Dr. Christopher Zarins. Thank you and welcome to this interview.
My pleasure.
Dr. Zarins, let's start out by asking you, tell me when you were born and where.
I was born in Latvia, December 2nd, 1943.
And tell me about your parents.
My father was a minister in Riga, Latvia. If you've ever seen the skyline of Riga, there's the Dome Cathedral, which was a grand old church that actually was built 1300. So it's a very old church. Riga itself is 800 years old as a city. And this was the most dominant architectural feature of the city, and my father was the minister in that church. Of course, it was World War II. He gave the last sermon in October 1944 in that church. Everyone else had already evacuated the city, or many people had. And then we escaped. 2 days later, the Russians came in after that sermon. And then we escaped on a little boat across the Baltic Sea to Sweden, where I was born in Latvia. I was 10 months old at that time. Then my father was recruited from Sweden to head the Latvian Lutheran Church in New York City. And so we came over in 1946, before all of the displaced persons from World War II really started to come to the United States. And my father, I grew up in the parish house in Brooklyn, New York, and my father went to Ellis Island, went to the docks, and he received, I think it was something like 267 refugee ships from World War II over the next ensuing 10 years. Many of the families lived in our house, and as they relocated to various places in the United States. So very involved with the post-World War II immigration issue. And so I've grown up in a Latvian environment. I speak Latvian at home, of course. My wife is Latvian. I speak Latvian with my children.
Wow.
And now with my grandchildren.
Okay, so before we get to the rest of the family, tell me about your mother.
Well, my mother, she was an English teacher in Latvia, and the main thing I remember from her is my mother always said, school comes number one. So more important than anything else was school, and so we as children grew up with education as the primary focus. And she was just a wonderful person.
And do you have siblings?
I do have a brother and a sister, and my brother is an orthopedic surgeon at Mass General.
His name?
Bert Zarins. He's also the team physician for the New England Patriots and Boston Bruins. So,
do you get to enjoy tickets? Do you get to enjoy tickets?
I've been on the sidelines for many professional football games.
That's better than tickets.
The real issue and the real problem was, of course, I spent many years in Chicago, and when the New England Patriots were playing the Chicago Bears in the Super Bowl, this was the 1985 Chicago Bears, and I was a very intense Chicago Bears fan because I was at the University of Chicago at the time. Yeah. So the Patriots were playing the Bears, and of course in the playoff games I was able to be at the sidelines, but in the Super Bowl in New Orleans, I was sitting in the Patriots box with the Patriots, group. With a Patriots hat on, but I had my Chicago Bears buttons and everything on inside of my jacket, because I was really rooting for the Chicago Bears, who won, of course.
Excellent.
I've got pictures from that, and my son was able to be a ball boy in the Patriots training camp, and as a child he was able to go to the training camp. We've got pictures of him doing push-ups on the field with Walter Payton. I've got pictures with him and Mike Ditka and the Honey Bears, and so yeah.
Oh, I'd love to see you with the Patriots hat, but with the Bears button.
I don't know if I have a picture of that, but...
Tell me about, you also have a sister.
Yeah, my sister, she was really a biochemist, and she worked in the orthopedics research laboratory for Henry Mankin, who came from New York and became the chief of orthopedic surgery at Mass General, and so she worked and ran his research lab. And she married an orthopedic surgeon, and they live in Lexington, Massachusetts.
Wow. Now, where are you in the order of the three
I'm the
children?
baby. I'm the youngest.
Okay, excellent. Now, growing up in the parish house, I'm sure it must have been fascinating, but what was your early education like then? Where did you go to school?
Well, I went to PS 77, which was down the street in Brooklyn. I went through the public school system in New York City, the PS 77, junior high school 51, and then New York at that time had 4 special high schools that required an entrance exam. Brooklyn Tech was one of them, Stuyvesant was another, Bronx High School of Science and Music and Art. I went to Brooklyn Tech, my brother went to Stuyvesant, so we were rivals because these were competitive schools. His school was in Manhattan, mine was in Brooklyn, so we had to travel to get to these schools. Oh. And of course my brother was a Brooklyn Dodgers fan at that time, and I was a New York Yankees fan, so we've been, in that sense, a little bit competitive as we grew up.
Funny. When you were young, what did you think you wanted to do for a living?
Well, that's an interesting question. I really didn't know. My brother knew. He knew he wanted to be a doctor, and so as we were growing up, everybody had jobs, and one of the jobs, he worked on construction during the summer, so, you know, hammering and sawing, so of course he went into orthopedics. But I sort of really didn't know what I wanted to do, but I know I really didn't want to work. And so the way you can avoid working is by going to school. And so I just went to school, and then I graduated high school in 1960, which was the year that the Russians sent up the Sputnik, which was the very first orbiting satellite.
Yeah.
And so at that time there was a big hue and cry that the United States was 50,000 engineers behind Russia, and that unless we had more engineers, that Russia was going to rule the world. Well, coming from World War II and the Russian invasion and occupation of Latvia, so I, of course, was going to study engineering. So, so I went to Lehigh University and started to study engineer, but there was a 5-year arts engineering program. And then I decided I enjoyed the arts more and biology, so I finished with a BA in biology, and then went on to medical school.
So why medical school? Something must have happened to make you think you wanted to do medical school.
Well, the greatest course in college was comparative anatomy. We dissected frogs and cats and fish, and looked at, and I was just fascinated by the anatomy. I just loved the anatomy, and so then to go to human anatomy from animal anatomy, comparative anatomy for different species, it was just an area that was just fascinating to me.
So where did you go to medical school?
Johns Hopkins.
Now, when did the idea enter your head the first time that you realized you wanted to be a surgeon?
Well, that also was kind of an evolution. When I was mainly more interested in doing something important than a specific thing. And in medical school, I said, gee, what do I really want to do? I want to do something that might, you know, change the world. And what's the biggest unsolved problem? And that was the human mind. And so I thought, well, gee, maybe I ought to become a psychiatrist, and you know, because of all unsolved problems.
Yeah.
And then my first summer in medical school, I did an elective, and I did a research elective during the summer in the psychiatry department in psychosomatic medicine. And I learned a lot, and one of the things I learned was that psychiatry is full of crazy people.
Go figure.
And some of the professors were as crazy as some of the patients.
Yes.
So I said, gee, maybe that's not for me. And then I really, I started to do, because of my interest in the anatomy, I got involved with research projects on animal surgery, and once I started actually doing things and being able to actually perform surgery in a research lab, and that really became clear that I could actually make change by doing surgical procedures. So that totally fascinated me, and then so that obviously led to surgery.
Whose lab were you in at Hopkins doing research?
David Skinner.
And isn't David Skinner one of your mentors?
He is, and that really was changing. I was a medical student, and David Skinner was a young assistant professor, just started. He finished his residency training at Mass General and then took a position as assistant professor at Johns Hopkins. And George Zeidema was the chairman of surgery, and so I had an opportunity to work in David Skinner's research lab on the 12th floor of the Blaylock building at Hopkins. And we did all kinds of really interesting things. And my very first paper that I ever wrote, it was my co-authors are George Zeidema and David Skinner and myself, and we actually did an extracorporeal portacable shunt using a benzalkonium heparin graft, which was because all these plastic tubes that you'd use for shunts and bypasses, they all thrombosed.
Yeah.
And they coated these with heparin coating. It was called benzalkonium heparin coating. Vince Gott was the thoracic surgeon, and he was using it to use a temporary shunt for thoracic bypasses to allow surgery off pump. And that same technology I applied to dogs to do portacable shunts through the umbilical vein, because the umbilical vein you could dilate, get access to the portal vein,
Yeah.
and then you could create a shunt from the umbilical vein to the jugular vein, therefore doing basically a portacable decompression.
Wow, that was your first publication.
That was my first paper.
Do you remember what year that was?
Gee, that must have been, when would that have been? I graduated 1968, so that was 1967.
Wow. Now, from Hopkins, you then went to University of Michigan for your residency.
I did.
How did that come about?
Well, I was really looking around to places that I could really do a lot of surgery, and was very impressed when I visited the University of Michigan with the enthusiasm of the residents and how much they actually got to do, which was a little bit different from Johns Hopkins, because Johns Hopkins, as a junior resident, you really didn't get to do much, but when you were a chief resident, then you did absolutely everything. And so the ability to start doing surgery earlier was really attractive to me, and so I chose to go to the University of Michigan. It was an absolutely terrific place to learn surgery, no question about it.
And when you were there, what field of surgery were you thinking you were going to go into? Had you already had the realization that you wanted to specialize in vascular, or not yet?
No, not at all. Vascular surgery didn't even exist at that time. Vascular surgery was part of general surgery, and the chief of general surgery was William Fry. Bill Fry was really one of the early pioneers of vascular surgery. He was a general surgeon, and in that era when Bill Fry was the chief, so many people who ultimately became leaders in vascular surgery came under his wing. It was Jim Stanley, you know, Pat Claggett, Jack Cronenwet, you know, all of these people, we were all there together as residents under Bill Fry, and so he really had a very pivotal role in setting the standard in terms of surgical excellence. And Bill Fry was a great academician, but more importantly, he was a great surgeon, and he really set the stage and the standard for me of surgical excellence, not just technical surgical, but patient care. Patient came first, no matter what you did, no matter where you were, a committee meeting, a research, what didn't matter, the patient was always number one. And so everybody was always there 24/7 for the patient. And Bill Fry lived that. He demonstrated that, and he was the role model for so many people who ultimately were absolutely superb surgeons in their careers. And they did research as well, simultaneous, but Bill Fry sort of exemplified the patient care and surgery for me, and David Skinner represented the academic side, and then kind of to bring all that together and blending and mixing academics and research with patient care is that's where the roots came for me.
And as I understand, yes, so Skinner was really one of your first mentors. Fry is really one of the second mentors on the scene for your career, and we're going to talk about another third very important person coming up. Before we get to that, tell me about Zinta.
Well, Zinta is the love of my life. We've been married 46, 47 years. She'll kill me if I get it wrong.
Well, I know you got married in medical school because I checked the dates.
It was 1967.
So a year before you graduated.
That's right, yeah. So I was a medical student and in Baltimore, and this was, there were unsettled times, and that was time of the riots and the Martin Luther King assassination, and we were very young, and at that time Zinta had just graduated college, and I was in medical school, and we got married, and she has been supporting me throughout my career.
How did you meet her?
Ever since.
But how did you meet her?
Well, so she was born in Latvia. And she grew up in Philadelphia. I grew up in New York. And Latvians have song festivals, and they have a lot of cultural events. I was in my father's church. There was a summer camp in the Catskills, and I was a counselor at the camp, and I was a lifeguard, and we'd sing Latvian folk dances and all of that. So every 4 years there's a song festival, Latvian Song Festival. It's a big cultural event, folk dances and choirs and singing. And this year it happened to be in Toronto. And there are also all kinds of parties, and all the young kids get to meet each other. And so I met Zinta at this Latvian Song Festival in Toronto.
Wow.
And then we corresponded. And then I invited her to come and visit. And she came and visited in Baltimore. This was about a year later, and I hadn't seen her at all that whole time. And then I asked her to marry me
Oh, that's...
a week later.
Oh, that's so romantic. Okay, so I don't get teary-eyed. And you're still married to this day. That's pretty amazing. And you have children.
We do.
This is what you get when a girl does the interview. Tell me about your children.
Well, we have 3 wonderful children, a daughter Dinah, my son Sasha, and a second daughter Karina.
And what do they do for a living?
And my oldest daughter, she actually works in the startup company I have, and she was our very first employee before we even had any funding or anything, and she was just doing that, and now she is the manager for human resources in our company.
Wonderful. And your other children?
And my son, my children have been sort of, my son and daughter are both in clinical trials and clinical research, and my son has been involved with a number of startup companies in California. Most recently, he's been involved with a number of companies that have been purchased by other companies, and most recently his wife is the VP for R&D for a company called Ardian. Ardian is radiofrequency ablation of the renal nerves.
Yeah.
And that recently was purchased by Medtronic. So as a result, my son is retired.
Okay, pretty nice.
And they have 2 wonderful little children. No, he started up his own business then as a result. So instead of working for for someone else, he now had the resources to start his own business. And my youngest daughter, Karina, she has worked for a number of companies with clinical trials. She's a CRO. And most recently, a fascinating company that she works for is called Oxygen. Came out of Stanford and does in vitro fertilization. So, if you do in vitro fertilization, you can tell if an embryo is going to be a good embryo after 5 days. But if you implant that embryo, it doesn't take. You have to implant it at 2 days. Well, at 2 days, you can't tell whether it's going to be a good embryo or not most of the time, and so they sometimes implant multiple embryos, and then you get twins or triplets or an octomom. So they have developed a technology where they do basically video observation, and they record the division cycles, and they can predict with an algorithm what the embryo is going to look like at 5 days, depending on what the division pattern of the cells are at 2 days.
Oh, fabulous.
And so they then can select the viable embryos and have a much higher success rate for in vitro fertilization.
Oh, that's fabulous.
So she's real excited about that, and she's running clinical trials for that company.
Your kids definitely have your genes, quite innovative. It's pretty cool. Okay, so now we left off in your training. So you are now finishing your residency career at University of Michigan. What came after that, after you finished your training?
Well, so the Vietnam War was there, and everybody was being drafted for the Vietnam War, and if you were going to school, then you got deferred. And so I got deferred through college and medical school and residency. There was a program called the Berry Plan, because they knew how many surgeons they would need in the military, and so they would defer the appropriate number of people, and then when you finished, you ultimately had to go in and serve. So after I finished my surgery training, then I owed the Navy 2 years of service, and it was wonderful 2 years, because I couldn't have had a better experience. What actually happened was I had requested a position at the Navy Research Center in Bethesda. They had 5 training hospitals for surgeons in the Navy and residency programs, and they needed faculty for that. But then they had one that actually was doing research, which was the Navy Medical Center in Bethesda. So I applied for that to spend my 2 years there, and was actually selected for that. And about a month before I was supposed to go in and serve, I got a phone call, and they said, would I be terribly upset if instead of going to Bethesda, they sent me to San Diego? So I said, let me think about that.
Yeah.
Well, so the Da Nang shock lung unit was in Da Nang, and at the end of the Vietnam War, they transferred that from Da Nang to San Diego. They had a very big Navy hospital in San Diego. And so that's where I worked. I worked in the Navy shock lung unit in San Diego. And I had a research lab, and I worked in the intensive care unit, and I'm doing critical care medicine, and I couldn't have had a better experience. And so I was able to continue research, had an animal lab. I was able to operate on baboons, looking at shock lung. And so while I was in the Navy, all the technologies for non-invasive vascular testing was being developed. And it really didn't exist during my residency at Michigan. But Arnis Fronik was at UCSD, and so I was able to go and visit with him, and I spent time at the VA hospital in San Diego and learned about non-invasive testing. So it was a wonderful experience. I couldn't have asked for more in the Navy, and I was considering staying in the Navy, because it was such a good experience in an academic sense, and the ability to work with the university. And so after my 2 years was starting to come to a close, and I went to the Admiral and said, well, gee, I'd love to stay in the Navy. I can continue to do what I'm doing. And he said, well, son, the needs of the Navy come first, and I could see myself being out there in some aircraft carrier in the middle of the Indian Ocean. So I said, well, maybe I'll go do what I had been planning all along, is to take a university academic position. And that year, that was February 1975, David Skinner was I think he was the president of the SUS, and the SUS was meeting in San Diego. And so Dave Skinner came and convinced me that I should take an academic position, and there was some big blizzard in Chicago, and the sun was setting in San Diego. It was warm, and it was wonderful. And he was a persuasive guy, and he convinced me I ought to move to Chicago, which is what I did.
So you started at University of Chicago in 1976. When you first started, what was your practice like?
Well, so that's an interesting story. I'd spent 2 years doing trauma critical care. I actually, as part of my residency, I knew a fair amount about the liver and biliary system because Gardner Child of the Child's Classification for Liver Disease was the chief of surgery at the University of Michigan. And there was Bill Fry's vascular training. And so Dave Skinner asked me, well, what do you want to do? Because he offered me a position, and so I could pretty much do what I wished. I could have said, gee, I want to do trauma critical care and develop that, or I could have worked on liver and biliary, or I could have done vascular. And vascular, of course, didn't exist. So I really was fascinating with the vascular procedures and the ability to do vascular surgery. And so I said, okay, we'll start vascular surgery. And at that time, aneurysms were being done by the cardiac surgeons at the University of Chicago. Vascular surgery was a non-entity. And so I started as the one and only vascular surgeon at the University of Chicago. John Bergen and Jimmy Yao were at Northwestern. And I got $20,000 seed money to start up my research lab. And that was sort of my package. And I used that $20,000 to hire a college student and taught him how to do non-invasive testing, plethysmography and OPG and things like that, and started up a vascular lab. And then from that, built the clinical program, which was the most important thing to build. And of course, you could always bootleg the research, and then I got the research started and going as well. And then built up the vascular program at the University of Chicago with that start in 1976.
That's amazing, and it became an incredibly strong division. One of the things, though, at your time at University of Chicago that I think you've even mentioned is very pivotal is your relationship with Seymour Glagos. Tell me about how that happened.
Yeah, so that's an interesting story. So I arrived at the University of Chicago as a young assistant professor, trying to figure out what I was going to do and how I was going to get things going. And now I'm supposed to be a vascular surgeon. And I said, gee, I better learn something about the disease that I'm supposed to be treating. And at that time at the University of Chicago, they had a SCORE, Specialized Center of Research in Atherosclerosis. And Bob Whistler was the head of it. And they had a very large research program with animals that were being fed a high cholesterol diet to produce atherosclerosis. And there was a prevailing thought that the cause of atherosclerosis was high cholesterol, and the way it localized was by endothelial injury. And Russell Ross had this hypothesis that high shear stress damaged the endothelium, you deposit platelets, you have cellular proliferation, you have lipid deposition, and that's the initiating cause of atherosclerosis. And so I went to Bob Whistler and I said, I'm really interested. I want to get involved with all of this research. And he said, well, why don't you go talk to Seymour Glagos? So I went and I talked to him, and we hit it off right away. And he happened to have one of those large grants. And he was looking for someone to do surgery on the animals because he had a whole colony of monkeys that needed surgery. So we started to study these monkeys. And one of the first projects we did was to look at the endothelial surface to see what the evidence for endothelial injury is. And one of the geniuses of Glagos was that he was such a visionary. He could see things years ahead of other people. And one of the things he recognized, he's a pathologist, he's a vascular pathologist. So, and he headed the autopsy suite. And so he would look at vascular disease in the morgue every day, and I would be looking at vascular disease in the OR. But he had the vision to realize that plaques don't bulge into the lumen. Every single textbook that was written had pictures of plaques bulging in the lumen. The surgeon would say, oh yeah, I operated on this patient, and I saw this plaque bulging in the lumen, and the disease is much worse than you thought because there's so much more disease, which of course is the way it looks, because you put vascular clamps and then the vessel collapses. So what Glagos's vision was that in order to see what a blood vessel really looks like, you have to pressure perfusion fix it. And so what we started doing in the morgue was we'd cannulate the vessels, and we would pressure perfusion fix the coronaries, the aorta, the peripheral vessels, the carotids. And in doing so, we now had a totally different vision of what atherosclerosis was. The plaques did not bulge into the lumen. The plaques actually pushed out, and the vessels, we had a whole series of experiments on adaptive enlargement and things like that. But Glagos had this vision, and we were sort of skeptics against the rest of the world, because we did not believe in the high shear stress theory, that high shear stress damaged the endothelium, and that plaques localized in areas of high shear stress. Yeah. But it was really the opposite. It was low shear stress, yeah. And that there was no endothelial injury or denudation. So I couldn't have learned more from Cy. I would talk to him every single day. His office was right down the hall from mine. Walking in the morning and in the evening, I'd stop in, we'd chat. Every time I did a case in the OR, I would stop in his office and show him the plaque that I'd moved in the OR.
You take it with you from the OR to his office?
Oh yeah, yeah. And then we would look at it, and then I would make rounds in the morgue, and then I learned more from visits to the morgue than almost anything, because there'd be pressure perfusion aortas. There'd be the worst looking aorta that you'd ever seen in your life, and it was from a 90 or 100-year-old person who had never had vascular disease in their life. And so this idea of actually testing hypotheses of what you think is really true against real life, either at autopsy or in the operating room, really opened my eyes to what the nature of atherosclerosis was. And it was different from the way most people were talking about it at that time. And this was so far before we had imaging, before we had, CT scans and intravascular ultrasound and ability to see in 3 dimensions what the real vascular disease looks like. This was a simple cut film angiogram, and that was the only vision that you had of a vascular lesion, either that or directly in the OR.
Well, I would say that the two of you definitely induced a paradigm shift in the whole concept of atherosclerosis, and I think that you have many contributions to vascular research and vascular biology, but that for sure is one of your very large contributions, adaptive remodeling. It's pretty amazing what you guys accomplished at the University of Chicago.
And there's another player, and that's Don Giddens.
Ooh.
And so Don Giddens, so here I was a vascular surgeon, there was Seymour Glagos, a vascular pathologist, and all of these thoughts and concepts about high shear stress and low shear stress. Yeah. Well, how do you actually measure this, right? So what happened was I had written an abstract about aortic ostia, about how the endothelium was intact in the area of aortic ostia, which was supposedly the high shear stress area. And that's not where you see the plaque, and that's not where, and you had no endothelial injury. So I wrote an abstract and submitted it to this specialists meeting that Bob Mirren organized at Ohio State. And it was a very it was a small closed meeting of specialists, and I wasn't invited. I was just a little junior guy, and Seymour Glagos went and presented this paper. And Don Giddens at the Georgia Tech, he was an aerospace engineer. He somehow got a hold of this abstract book. It's not published, and read it. And he called, I was the first author, so he called me. I wasn't there, I was in the OR. And so he called the second author, Kathy Taylor. And so she said, yeah, we did these experiments. And then he called Glagos, and Cy said, well, yeah, why don't you come on up? So all of a sudden, Don Giddens comes from Georgia Tech. And he was very interested in our theories. And what he had was a carotid model, a glass model that I'm sure you've seen pictures of. And he had done this, and he was using steady flow, and he had a laser Doppler anemometer. And so he was able to actually quantitate wall shear stress. And so we said, wow, so now we've been talking about this, but now you can actually measure it. And so we said, well, let's see if we can actually prove that it's the high shear stress that protects it, and the plaques form in the low shear stress region. So we said, well, let's try the carotid, since he had the carotid model.
Yeah.
So how do you get human specimens for the carotids? Well, you can't, right? Because in the autopsy, they perfuse the common carotid artery, and the most important thing for the undertaker is to embalm the face for the funeral. So you can't, and so I said, well, gee, I got to get a hold of those carotid bifurcations. So I said, okay, so I'll go down to the morgue. And so I dissected out the carotids, I harvested the carotid and left a cannula in the external carotid. And then the undertaker was willing to let it happen, because then he could perfuse and fix the face through the external carotid. And so then I harvested these carotids, and we pressure perfusion fixed them. And then we had to put markers in so you know the orientation and things. And then, to do a quantitation, you had to do manual planimetry, and you had to know where 0 degrees was and 90 degrees was.
Yeah.
And so ultimately, we wound up with 12 carotids, and we correlated those 12 carotids to the flow patterns in those models. And that was a paper that we wrote, and to this day, what's that now, 35 years ago, it's still true.
Yeah.
Now you can prove it with all the other techniques, but that's the manual process back then that we did to really show that. And it's interesting, speaking of the SVS, we worked very hard on that, and I wrote what I thought was a perfect abstract, and we had statistics, and we had correlations, and we had quantitation, and we had everything rejected by the SVS.
Oh.
So we worked some
We've
more
heard
on
that before.
I worked on that, and then submitted it next year, rejected by the SVS. And so finally, we just published it in circulation, and now it's been quoted,
Oh, wow.
ever since.
Oh, wow.
But that went on. But the important thing of that is really that it was a model of quantitation and a quantitative analysis of atherosclerosis, using human disease as the model, and then validation of concepts in experimental animals. But the real validation is against human disease.
Yeah.
So that's what really I learned from Seymour Glagos, and we had such a fruitful collaboration for so many years, and he was just a genius in his foresight and being able to see things and visualize what the disease really was. From autopsies, he could see the living thing, which was really amazing.
He was an amazing man. I also was fortunate enough to meet him. As you know, I went to medical school there. But he is also the person you consider to be your third major mentor in your career, am I correct?
That's definitely true.
Skinner, Fry, and then Glagos.
Correct.
So that brings us now to the portion where you then kind of enter a different phase of your career. So you went from University of Chicago to Stanford. Tell me about that.
I really enjoyed the University of Chicago. It was absolutely in terms of an academic environment, I couldn't have had it better.
You were there for 17 years, from 76 to 93.
Right, and I was really able to integrate clinical practice and research and teaching because I actually had a very unique physical environment. I had my office. Directly across the hall from my office was my research lab.
Oh, nice.
And I could operate in animals at that time in my research lab. One floor directly below me was the operating room.
Nice.
Around the corner was Glagos. So I could be literally doing cases in the OR. Between cases, I could do an animal experiment. I could take my pathology specimen, I could go down the hall and talk to Glagos. And so it was physically all in one place.
Yeah.
And that kind of a environment where you could actually do integration in a real sense of research and clinical practice. So it was really absolutely an incredible, wonderful environment. And we had terrific residents and fellows and research fellows, and it couldn't be a more stimulating environment. And so they were trying to now find someone to develop vascular surgery at Stanford, because Stanford was, I think, one of the last places in the world that developed a vascular fellowship. And everybody else had vascular fellowships, but Stanford did not, because it was part of cardiac surgery. And so they were trying to find a chief of vascular surgery, and they asked, was I interested? And I said, no, I'm not interested. I've got everything I need here at the University of Chicago. And so they said, well, would you come out as a consultant? And so I said, sure. So I went out as a consultant, and I gave them a list of recommendations that they would need to do if they wanted to build a proper vascular program. Yeah. And they said, oh, that's impossible. We can't do that. And then over the course of a year and a half, all of the things that I said they should do, they actually did. And then it actually started to look like a pretty good opportunity. At the same time, with my multiple visits to Stanford, I encountered Tom Fogarty, and I also encountered Mike Dake, and I saw some of the things that were happening out there. So this was in 1992 that I started going out there on these consult type visits, and Mike Dake had just done the first homemade thoracic stent graft. 1991, Perotti had done his. It was sort of, people were starting to hear about this, and then 1992, Mike Dake did a homemade thoracic stent graft at Stanford. And I got to know Mike in my visits, and I said, gee, wow, this is something that is certainly not happening at the University of Chicago. And Tom Fogarty had been at Stanford. He had been a cardiac surgeon. Norm Shumway, of course, is the big figure in Stanford. He was a cardiothoracic surgeon who was a big heart transplant king. And he had fired Tom Fogarty years ago from the Stanford faculty. He said, Tom, you're not going to amount to anything, you know. And so Tom Fogarty went to Sequoia Hospital. And from Chicago, I of course knew who Tom Fogarty was, but I thought he was at Stanford. No, he wasn't at Stanford. He was at Sequoia Hospital. And so I started talking to Tom. I said, listen, Tom, there's this opportunity. Would you be interested in coming to Stanford? And so Tom was interested, and Mike Dake was there, and all these pieces started to become very unique and very attractive. And so I finally took the position in 1993, and the first thing I did was I hired Tom Fogarty and put him back on the faculty of Stanford, and got a chance to work with him, obviously, in this new technology of endovascular aneurysm repair. And initially with homemade devices with Mike Dake, and then of course Tom Fogarty invented the Anurex stent graft, and we did the animal trials on that, and you know, it's history since then.
And we were actually fortunate enough to interview Dr. Fogarty just a few weeks ago as part of the series too, so there were some entertaining stories there. I also want to point out, I thought this was fascinating, because you said your first visit as a consult to Stanford was in '91, but in '88 you had this commentary in JAMA, which I thought was fascinating because you actually call out and point reference to the Stanford vascular program. I don't know if you remember writing that. The Vascular War of 1988, the enemy is met. And I will say that was definitely entertaining reading.
So do you want to know the story behind that?
Sure.
So I was at the University of Chicago. Back in those days, it was the laser procedure, and everybody was buying lasers
Yes.
to open up superficial femoral arteries. And so I get on my desk a manuscript to review for JAMA, and they say, would you review this manuscript? The title of the manuscript is The Vascular Wars of 1988. And so it's written by Lou Wexler, and there was one other author. And in it, he says how they have solved the problem of interdisciplinary discord, which was going on big time at those times. And he said, we have a one-stop shop, we have a conference, and we review all of the cases, and then we determine who needs to have interventional endovascular procedure, and then we do it, and everyone's on board, and everyone's happy, and we have no problems at Stanford. And so I read this very interesting article, and I said, gee, that's very interesting, and you have the vascular surgeons on board and so on, but why isn't the vascular surgeon a co-author of the paper if everyone is on board? It was just the radiologists who wrote this paper. So I wrote my comments and so on, and since they had said the Vascular War of 1998, I sent my review in, and then JAMA writes back to me and said, we've decided to accept the article, would you be willing to write a commentary? So I said, sure. And since the title was the Vascular War 98, then I used the same title and put the enemy is met, the pogo thing, the enemy is met, and then them as us. And so I wrote my commentary based on having read their paper. I saw nothing else. And then when it came out in JAMA, they put my commentary first and their response as second, as if I had started the Vascular War of 1998.
Oh no!
So that's how that happened. So a lot of people took notice of that, and one of them was Victor Zhao and John Cook. And they then wrote a paper for the Annals of Internal Medicine, I believe, saying that the time for vascular medicine has come. That those guys are all fighting vascular medicine, we are going to now fix the problem. And they were both at the Brigham in Boston. So this whole thing was going around in circles, and then 2 years later or something, Victor Zhao is at Stanford as the head of cardiology. John Cook is at Stanford. I'm at Stanford. Lou Wexler is there. And so all of these people who were involved in this controversy all wind up now being at Stanford together. And we actually did work very well together, and it was really a stimulating, productive time. But
that's a good story. Well, and the other thing,
story, that's the basis of that story.
I was struck that this was written 24 years ago, and you almost could read this as if you wrote it today as well. So that's another interesting commentary on this. I actually, when I was reading this, I almost assumed you wrote this while you were president of the SVS, but again, this was much earlier.
Yeah.
So I think incredibly insightful for the time. That was interesting. So you spent almost an equal amount of time at Stanford in your career as you did at University of Chicago, because you started in Stanford in '93, and obviously you were involved in a lot of different aspects of vascular surgery, from endovascular to training fellows. You've trained numerous fellows. But the one thing I'd like for you to touch on is your involvement in innovation and how this led you to then be affiliated with Dr. Fogarty's Institute.
So when I arrived at Stanford, we already talked about some of the work that we did in Chicago with Glagos and Giddens. And when I arrived at Stanford, I organized a little symposium and invited Glagos, invited Giddens, invited some of the imaging people from Stanford, and we had a whole day symposium. And I gave a speech on hemodynamics and atherosclerosis. And after that, a student came up to me and he said, "Gee, that's kind of interesting. Do you have a project for me?" He's now looking for a PhD project. And so I said, "Sure, why don't you solve the three-dimensional pulsatile flow field for the human abdominal aorta?" This is something that we'd been kind of trying to do for about 10 years with Don Giddens, and you know, hadn't gotten very far. And so this, now the student's name was Charlie Taylor. And Charlie was a PhD student, and in 1 year he solved the three-dimensional pulsatile flow field. He hooked 40 parallel Cray computers together, which was at that time the world's largest computer.
Oh my God.
Those computers were actually in Silicon Graphics. Silicon Graphics, at that time, all those computers, I think the second or third largest computer in the world was for making Hollywood movies, imaging Jurassic Park and how do you make the dinosaurs move and things like that. It's all computational image analysis. So, and Charlie then, in 1 year, solved the pulsatile flow field for the human abdominal aorta, and it was good enough for him to get a PhD, but it wasn't good enough for him to get a faculty position at Stanford, because the Stanford Engineering School doesn't hire its own students. So I hired him, and I hired him on the faculty in vascular surgery, and he was an assistant professor in vascular surgery. And being now in the medical school, he came to all the clinical meetings, he came to rounds. All of the very smart engineering students from Stanford wanted to work with Charlie because he had access to human information, and very different from the engineering where they had no real link to real disease.
Yeah.
And so now Charlie, working in the medical school, now used the computational techniques, all of the same kind of things that we did with Glagos and Giddens, using very just artificial techniques. He now could have real human imaging, three-dimensional imaging with CT scans and MRs, and do computational analysis. And so now we transform that same kind of fundamental hemodynamics, atherosclerosis ideas that we were working in Chicago now in a computational sense. All of that now was being done at Stanford. And that then ultimately led to the current interest through the Fogarty Institute, which was your question. But before I get to that, let me tell you about the SVS in 1998. This was the year before I was the president of the SVS. And so my job as the president-elect was to do the Critical Issues Forum. So I said, well, we got to do something new and innovative and something different. And so I said, well, let's do this computational analysis for the critical issues. And so I said, Charlie, okay, we're going to put this together and we're going to now apply these techniques to decision making and solve vascular problems. We again got resources from Silicon Graphics and their big, huge computer network, and we built now this predictive modeling for occlusive disease. Should you do an aortoiliac bypass, an aortofemoral bypass, an axillofemoral iliac angioplasty, and a fem-fem, and we did computational flow analysis, and we could compute pressure and flow and predict what the outcome was going to be. And then in the Critical Issues Forum, we had on the stage, we had Norm Hertzer and Frank Veith and Jim Stanley and they were the panelists sitting at the computer solving these flow problems in real time in front of the audience as part of the critical issues.
Fun.
So that was pre-computed.
Yeah.
So now that same thing has to be, now 10 years after that, is make it real time for patients. And that's now the technology transfer from all of this many years of research into the actual clinical arena for patients, and that's where the Fogarty Institute comes in. And the Fogarty Institute, we formed as a place for taking things and helping young innovators actually develop something that's useful clinically. And that's what the Fogarty Institute really is set up to do. And so Charlie Taylor and I were able to take this idea and take it out of the lab at Stanford, and working at the Fogarty Institute developed this now as a computational method for analyzing coronary blood flow. And so we use 64-slice CT scans for the coronary anatomy and apply the fluid dynamics principles and do computational fluid dynamics to compute coronary blood flow, simulate hyperemia as if you gave adenosine, and compute fractional flow reserve and predict the need for coronary stents.
That is fascinating, and that actually is the technology that you have formed a company on.
Yes. Yes, this is a company, it's called HeartFlow, and it's really focused on computational analysis of human coronary blood flow, and the clinical purpose is really to determine whether or not you need a coronary stent or to best plan treatments. Could be coronary bypass as the best treatment, or medical treatment. And right now most coronary disease and most vascular disease is based on the visual estimate of the degree of stenosis.
Yeah.
And it turns out, as you know, that's not very accurate. So that, and it makes a difference because now you can have functional testing and you can measure it with a pressure wire at the time of coronary angiography by giving adenosine. And so if we can do it non-invasively, and then we can predict which patients need coronary stents and also which ones don't. Because right now a lot of people who don't need stents are getting them, and a lot of patients who do need stents are going home and then coming in with acute coronary syndromes because they're not discovered and they're not treated appropriately. So hopefully this will have an impact on benefiting a lot of patients in the future.
I think it's fascinating technology. And do I understand that you are now working full-time for your company?
I am, yes.
That's amazing. That's going to be great to see that technology in the clinical arena. Now, you have done so much academically as far as research and training and being involved in vascular surgery at a national level. But one thing that I think is incredibly unique and aspiring about you, and that I was fascinated learning, is your involvement with Latvia and giving back to Latvia. And I want you to tell me a little bit about that, because I was fascinated to read about your first time going back to Latvia after you left at the age of 10 months. You went back in 1986 to attend a meeting. Tell me about that.
Yeah, that was really a totally unique and very emotional experience. Growing up, of course, and being World War II refugees and the Iron Curtain coming down, you know, we preserved Latvian culture, tradition, language, and so on, but never dreamed that I would ever be able to see Latvia, or even if it really existed. It was an idea, but it was the Iron Curtain was such that what reality was kind of an unimaginable thing. So Seymour Glagos went to an international conference, and he met a Latvian pathologist, biomechanics expert, and she invited him to attend this World Congress in Biomechanics. And during the time of the Soviet Union, actually Riga, Latvia was the second best medical school in the whole Soviet Union. There were Moscow, and then there was Riga. And they had medical students from all over the Soviet Union. They had professors. They had a very active academic, medical, and surgical presence and research. And so they were now the organizers of a World Congress of Biomechanics. Well, Glagos couldn't go, and so he suggested that they invite me. And so I get this invitation, please come to this World Congress and give a talk. And so, of course, I accepted.
And to be clear, this is still under Soviet rule.
Yes, this was 1986,
yes.
And Latvia didn't regain its independence till 1991. So you had to fly to Moscow, to the international airport, and then you'd had to take a cab across town to the local airport, Sheremetyevo 2, to fly internal. So then from there you could fly to Riga. And so we get to Riga, go to the hotel. I go the next day to the conference center, and there are 1,000 people in the audience, and it's a simultaneous Russian-English translation. And people from all over the world are there giving speeches, either in Russian or in English, most people in English.
Which, those were the sanctioned languages you were supposed to be speaking at that meeting.
Yeah, so the Latvians organized the meeting, but they were all speaking Russian because that's what they had to do. And so I had studied Russian in college, and so I got up to give my speech, and so I addressed everyone in Latvian, and I was the only one in the whole meeting that actually spoke. Well, they spoke Latvian, but no one used the language in the meeting. And I gave my introductory comments in Latvian, then I read in Russian, and then I gave my talk in English. So I got a lot of attention, and I got a lot of special treatment. We had a limousine, a big black limousine that would drive us anywhere we wanted to go. Of course, it was the KGB, because they wanted to know where we were going to go. So
not the kind of attention you want.
And so they wanted to know who I was going to talk to, and so that there was always somebody there. But I got to know some of the Latvian physicians and some of the researchers, and I realized the high level of scientific work that they were doing, which was a total mystery to me. And then just to get to see my relatives who I'd heard about, who I'd never even knew whether they were alive, to actually see them, to go visit the family graveyards and things like that, and it was such an emotional experience, really. And where my father had preached in the church and everything, it was really, really amazing. And then my brother went to a meeting of the year later, an orthopedics meeting in 1987. And then my brother started to say, well, gee, why don't we organize a meeting, because there are a lot of Latvian physicians outside of Latvia, why don't we organize a meeting? So there were promises, yeah, we'll do it, and this was 1989. So my brother went, and he's an orthopedic surgeon, and so it was very interesting because you couldn't get permission. Say, yes, we want to have the meeting. No, you can't have the hall, you can't get this. There's all kinds of reasons why it couldn't happen. And so the official, they had this one official big Congress, but there was this big picture of Lenin on the wall, and my brother said, I'm not going to have a meeting there. I refused to go. and so it turned out that there was a big sports congress, where they had big sports events. And the person who was running that Congress had a problem with their knee. And so they called my brother to consult. He checked out the knee and went and did an arthroscopic procedure in the hospital and so on. And the person who was running this sports complex was very grateful, said, okay, well, you could use this thing. And so he had now a venue and a place to do it. And he was about to leave, and they went to the minister, and somehow he signed the paper, yes, we could have it. And then, so that's how the first World Congress of Latvian Physicians happened in terms of an organizational sense. And then we got the permission to do the very first charter flight from Stockholm into Riga without going through Moscow. And the Latvians put together such an incredible meeting. There were about almost 400 or 450 physicians from outside of Latvia that went. We were at the head of this parade. There were about 10,000 healthcare workers that paraded through the city.
Oh my gosh.
They flew the Latvian flag for the first time.
Oh my gosh, and I understand it's this first World Congress that really kind of contributed to the whole movement, right, of independence?
Yeah, and I guess the physicians were not politically a threat. So they allowed this to happen because these were just the doctors. They respected the doctors. They had this huge medical center in the Soviet Union. And so the physicians were politically non-threatening, but they had a lot of power and influence in the Soviet Union because they were taking care of all of the political leaders, you know, in terms of their health.
Yeah.
And so, but they were very surprised to see the nationalistic fervor that came out of nowhere when that Congress happened.
That's fascinating.
And then after that, then of course they declared independence and became politically free again
in 1991. And I understand, was it after that that you also started organizing shipments of medical supplies?
Right. So as soon as Latvia regained its independence, then Russia, of course, cut off all ties and refused to give any sort of support, and there was a huge shortage of supplies and equipment and medication because with the collapse of the Soviet Union and all of the resources which used to come from Russia now were all shut off, so that we were trying to supply them from the West, and we were organizing shipments and donations and things like that.
Well, I have to say that, you know, your involvement in Latvia it's an incredible story. And in 2003, you received the highest civil award that's given by the Republic of Latvia, the 3-Star Order Award. What did that mean to you, to receive an award of that stature from your homeland?
Well, that was really something special. And what really makes it special is that not only I got one, but my brother got one and my father.
It's pretty amazing. I mean, you really are a story of giving back to your roots, and I have to say I was very inspired reading about it. I told you that coming into this. So I want to ask you some final questions about academics, and these are more some global questions. Medicine's changing today, as you know. What are your thoughts about the future of academic surgery and academic medicine?
I think, you know, it is changing. It'll be different, but I think academic medicine and academic surgery will still lead the way. It's the most important entity because that's where we train the next generation, and they have to learn somewhere. And first of all, I learned from my professors and my mentors. You watch what they do and you learn by example as much as by their teaching. And so academic medical centers, I think, have the premier cream of the crop of faculty, and they will serve as the guides and the mentors for the next generation. And so I don't see that happening in the private sector in terms of setting the standards of quality, of ethics, of science, and advancing the field for the better of mankind. And I think that's going to continue. I don't see it happening any other way.
And what did it also mean to you to serve as president of the Society of Vascular Surgery?
Well, that was really the pinnacle of my career. You know, to have your peers, your colleagues recognize you and give you an opportunity to lead, and it was something very, very special to me, and it meant the whole world to me.
We also learn from challenges that we face and hopefully overcome. What do you think is one of the greatest challenges that you've had to face in your career?
That's a very good question, an interesting question. I think that the biggest challenge is really how to care for my family while I'm trying to do all of my academic work and my clinical work. And I've always been 100% committed to both my patients and my family, and to try to be there all the time for both, I think was the biggest challenge, and I'm gratified that I've got great kids and a great wife.
Yeah.
And without their support, I couldn't have done what I've done professionally.
Yeah. What advice would you give to young people who are in training now and who are considering pursuing careers in surgery?
Well, the number one advice is to remember that it's a real privilege to be a surgeon. Not everybody gets that opportunity. You have to earn it. You have to keep earning it every day. And you earn it through your commitment to patients. And while keeping that foremost, for those who have academic interests, I think to try to integrate your academic interests with your clinical interests, I think it is probably difficult. And I don't know how anybody would really be at the top of a research area that is disassociated from your clinical area, because the commitment is so intense and so deep that if you focus on research, then you're not necessarily going to focus on clinical, and vice versa, unless you can, it's all one and the same. And I was fortunate in that my area of interest, atherosclerosis and vascular disease, research-wise, was the same as my clinical interest. And I think that's what actually enabled me to carry on both functions satisfactorily.
What would you like to say to your mentors, if you could say it to all three of the ones we talked about?
Thank you.
I have to say that I was also reading your presidential address from the SBS, and I think something that you actually said in general, as I believe some of your kind of rules for academics, there's one quote that I think really describes you and your career so incredibly well, and it came from you. It's generate new knowledge, for knowledge will lead the way. And when I read that, it really made me think that that's basically what your whole career has kind of been about. And I just want to thank you. I want to thank you for coming here and allowing us to interview you today, and thank you for all of your amazing contributions to vascular surgery.
Thank you.
Thank you.